where the hypothalamus strives to maintain homeothermia. We talk about homeostasis in the context of fluid electrolytes. Homeothermia means we have a predetermined range of normal temperature that our body prefers. For our human body, it's 96.8 to 99.5, or it's 36 to 37.5. Occasionally, you'll see a source that will say it's 97.0 to 99.5. But that is our normal body temperature. But if you remember, we talked before about how sometimes there are things that are outside of normal that are not necessarily treated. They're simply observed. So when a physician sees a temperature 99.6 to 100.3, they will often wait and observe as opposed to treat. So a lot of times when an antipyretic or something is ordered, he doesn't expect you to give it at 99.6, he expects you to give it at 100.4 or 100.5 or greater, okay? It does not mean that that's normal range. Page 479, under alterations in body temperature, very first sentence, says it in black and white. The normal range for adults is considered to be between 36 and 37.5, 96.8 to 99.5. Our bodies produce heat. It cannot produce cold. Cold is considered a deprivation, or the absence of heat. So again, out on your A&P review, I talked about how our body produces heat and how our body loses heat. There is no production of cold or loss of cold. So let's look at some of those factors that affect temperature. So your first, next two slides, I'm going to kind of elaborate on those. Those are actually the broad categories of information. The first slide is pretty much listed in your book. Some of the others have been added as well. First one is age. Infants and children have a difficult time regulating their body temperature. So many times they're much more vulnerable to extreme temperatures as far as too hot or too cold. Our bodies naturally lose a lot of heat through our scalp and through our head. And so an infant and a child, because their head is disproportionately larger than their body, loses an even larger amount of heat from their head. That's why the pink ladies at the hospital will often provide a knitted cap for those brand new babies born in the nursery to help maintain those body temperatures. Children will often produce a very high fever. It doesn't mean that they are more sick than an adult with the same issue. It's just they don't have as good control over those extreme effects that their hypothalamus produces. Older adults, on the other hand, also have trouble regulating their body temperature, but it's for different reasons. In their situation, their body has lost some of its effectiveness as far as regulating temperature. They also often eat more poorly, so their diet doesn't necessarily have enough source of calories to keep them warm. In fact, many times they've lost subcutaneous fat over the time. That's why their upper arms wave at you when they raise their arms up. You know, they sag and wave. You know what I'm talking about there. Lack of activity. Again, when you look at our A&P review, muscle activity generates body heat, and then our circulatory system disperses it throughout our body. So if your muscles are not moving because you're sitting around most of the time, you don't generate as much body heat. So they have trouble regulating it in a colder environment. The external environment does play a factor, and by external, I don't mean necessarily outside a building or outside a house. I mean outside the human body. In other words, if you have grandma and grandpa over, or you have a brand new baby in your home, and the temperature that you like to have your house at is 65, those individuals are going to suffer from that temperature because that's so much colder than what their body is used to. So extremes of either direction, too hot or too cold, affects our body temperature. Circadian rhythms. You were asked as part of the prep work to bring body temperatures that you had checked. Was it 3 times a day? I think it was 3 times a day. Before each meal and bedtime for 3 days and bring to class. So very quickly, turn to page 299, and I want you to plot those numbers as quickly as you're able to for those 3 days. So the temperatures on the left-hand side, those are all in Fahrenheit, obviously, and then the times of day are listed there. Not necessarily that you ate breakfast at 7 or ate lunch at 12 or ate supper at 5. That's just to evenly space them out across the paper. So very quickly put those dots on that paper and connect the dots. And I'll give you just a moment to do it. I want you to look at the trend that's on your paper, and let me just briefly touch on circadian simply means cyclic, meaning that our bodies are set to run on an approximate 24-hour schedule. And what I mean by that is it's slightly less than that or slightly more than that. I've forgotten now exactly which it is. But basically, your body releases hormones at certain times of the day consistently that affect your metabolic processes. And as a result, your body temperature, the human body typically has its lowest body temperature each day between 4 a.m. and 6 a.m., and its highest body temperature between 4 p.m. and 6 p.m. Now, for those of you who just plotted your temperatures, raise your hand if that was consistent with the numbers you have. Anybody observe that? Raise your hand if you did. Okay. I had 3 on this campus. Did anybody on the other campuses observe that? I see 1 in Top Ball.
That's what I was gonna say, we have 1.
Okay.
We have some over here in Enid.
Okay, very good. So why is that significant is we need to recognize that the human body may vary as much as 1.8 degrees from morning to evening, and that is not because of infection or illness. That is a normal circadian rhythm, and we need to interpret our vital signs accordingly. Hormones. Females vary their body temperature as much as 0.5 to 1 degree, depending on where they are in their menstrual cycle. Progesterone increases the body temperature, and it during that time of ovulation. So we use that to promote fertility for those couples who are having difficulty getting pregnant. Cellular metabolism. So we talked about basal metabolic rate in the nutrition lecture. Mrs. Hay talked about that a little bit. But we also have an organ that regulates our metabolic activity, and that's our thyroid gland. So our thyroid and our metabolic rate influences our body temperature because the release of thyroid hormone, thyroxine, increases how fast our bodies generate energy, and as a result, how much heat they produce. Eating and drinking. So the temperature of the item that you consume, whether it's hot or cold, will alter the temperature of your GI tract, and can then, because the GI tract is lined with a great deal of blood flow, especially the esophagus and the small intestines, then as a result, we can actually heat or cool up our body's blood by the temperature of the things we're eating or drinking. That's why a hot cup of cocoa or a hot cup of coffee makes you feel warmer after you've consumed some of it. Smoking. The temperature of cigarette smoke is very high, I don't know how accurate the numbers are. It seems crazy to think that they are as high as what my son claimed he read one time on the internet. He claimed they were several hundred degrees. I don't think that's true, but I certainly know they are hotter than your body temperature because your body temperature doesn't ignite a cigarette. Okay, so the end of the cigarette is obviously hotter than you are. So that hot air inhaled, because again, the blood flow to the alveoli heats up the blood. So again, many times when a smoker is cold, they light up a cigarette in order to feel more warm, and it works. But on the other side of the coin, nicotine, the primary substance that is addictive in nature, causes what to the vascular system, Stillwater? Vasoconstricting. So if you're smoking in a very hot environment, you're actually doing yourself harm as far as the body temperature is concerned. You're conserving heat when your body is really wanting to get rid of it. Okay? And then when you increase your pulse with that nicotine, you also increase your metabolic activity and heat production as well. Stress. Stress, as we talked about in the anxiety and stress lecture, produces that fight or flight response. Whether it's mild, moderate, or severe, we release epinephrine and norepinephrine, and both of those increase metabolic activity and heat production. So someone who is anxious and stressed may actually have a slight elevation to their body temperature. Muscle mass and body fat. Remember, muscle movement, muscle activity is what generates body heat, and body fat, not body feet. I guess if you put your feet all over your body, maybe it would work, but body fat, it insulates your body so that since it's on the outside of the muscle cannot dissipate that heat as easily when a person is overweight or obese. Infection generates an increase in temperature, but we're going to look at that more in depth later, and we're going to refer to that as fever. Exercise, again, because of muscle activity. So exercise, depending on how vigorous it is, can elevate a body's temperature as much as 4 to 7 degrees above normal during that most active time. Dehydration. Dehydration, as we're going to talk about here in a little bit, plays a factor, or actually as we talked about in the A&P review, sweating is part of how we get rid of excess body heat. So if we don't have enough fluids on board to be able to produce adequate sweat, we develop a problem we're going to talk about in a little bit called heat exhaustion and heat stroke. So dehydration affects our body temperature. Head injury, because our hypothalamus sits just on the underside of our brain, then a closed head injury can damage the hypothalamus or its ability to regulate your temperature. Likewise, a stroke. We'll talk about that in the spring. A neurological injury that happens to the brain, similar to what an MI is to the heart. And again, if that part of our body has been affected by the CVA, then our body temperature will be out of control as well. All right, so today we're going to divide our nursing problems into two broad categories. A problem with the body being too cold or too hot. So when we're talking about too cold, we're primarily looking at one problem. We talk about too hot, we're going to look at 4 different problems that the body might experience. So let's look at hypothermia, or being too cold, first. So I'm going to give you some time to write down this assessment data. Remember, these are things that we would see with somebody who cannot bring their body temperature back up to where it needs to be. This is somebody in a cold environment, somebody who's having trouble bringing that body temperature up to that homeothermic place. So the temperature is going to be less than, now some sources will say less than 96.8 qualifies for hypothermia. Other sources will say the body temperature typically needs to be less than 95. And again, let me explain why there's a discrepancy. Because if you were out in a 39-degree temperature waiting for the school bus and you had a jacket on thinking it wasn't going to be that cold, you might drop below 96.8 for a brief time, but not be experiencing the rest of these signs or symptoms. But once you get down to 95 or less, you're going to start developing all of these other symptoms, and it's going to take some time to recover from that. So your skin's going to be cool to cold because of vasoconstriction. The person's skin may be very pale. But peripherally, so out in the extremities, they will often be blue or cyanotic. Because of that alteration in perfusion, they will have a decreased capillary refill. It will take much longer than our less than 3 seconds to refill their fingertips, if they can at all. In order for somebody to reach hypothermia, they have to be exposed to a cold environment. So what does that mean to you as a nurse? So when you're at the nursing home and the temperature is regulated to be 78 in the room, and you check somebody's body temperature and they're 94.8, that's not because they have hypothermia. That's because you didn't get an accurate temperature reading. Okay, it's just that simple, all right? Shivering. Shivering is a rapid attempt to create minor muscle movement, but to generate energy and heat from doing so. Piloerection. Tonkwall, what's piloerection? What's another word for that? Goosebumps or goose pimples, yeah. Drugs, alcohol, or anesthesia. So basically in this situation, we're altering the person's ability to respond to feeling cold. So somebody who's intoxicated or over-medicated or anesthetized cannot cover up with more layers of clothing, or they cannot go get a warm drink to consume because they can't respond to that stimulus. And as a result, they can die from exposure if they're in a motor vehicle accident. Now, obviously, somebody driving down the road should not be receiving anesthesia, but in the post-op time is what I'm referring to in that context. ETOH is alcohol. It's the chemical name for ethanol, which is the kind of alcohol that people use. It's also, ironically, the kind you put in your car. So just keep that in mind the next time you want to go out and get wasted. You're putting something very, very similar to what you're putting in your gas-guzzling car.
Makes sense to me.
Okay? Okay, decreased level of consciousness for the same reason. Those three things alter your level of consciousness, but if you've had any other reason to lose consciousness, such as a low blood glucose, such as hypoxemia, such as a blunt trauma to the head, those things can also produce hypothermia. And when that occurs, things slow down. Okay? So you're going to see some changes in their vital signs, not just their temperature. So what do we do for those people? Well, the very first thing is, because we're changing that person's body temperature is disrupting the environment that those organs want to work in, there's a possibility they will die. And so our ABCs are our first priority. We want to assess and make sure that if they're intoxicated, anesthetized, or have drugs on board, or have had a head injury, that they still actually have a patent airway, and that they are still breathing, and that their circulation is adequate. Even if it's not adequate to the periphery, we want it to be adequate to those core vital organs of their trunk and their head. So one of the things about cold is that it produces a very irritable heart. In other words, that heart is very susceptible to lethal arrhythmias developing just with movement of that individual. So they may develop bradycardia, as I mentioned in the previous slide, but they also may develop what we call ventricular fibrillation, which when that occurs, they have no pulse, and they have no blood pressure, and they have no permanent life unless you do something about it. So when a person comes in and they are hypothermic, that's one of our primary interventions, is put them on a monitor so we can see what's happening before it happens and catches us off guard. Because remember, they have a decreased level of consciousness. We don't know if that's because their heart's no longer circulating blood to their brain, or if it's because of some other issue. So vital signs with core temperature checks. Core temperature is, again, from our A&P review, that's that temperature of the trunk of the body. So the internal organs of the body, what temperature are they? So core temperatures are measured either tympanic, temporal, or rectal. An oral temperature is not considered a core temperature. A axillary temperature is not considered a core temperature. Hold on, give me just a second, let me think of the word. I can't think of the word, but We can actually measure body temperature inside a person's bladder, as well as within their vaginal cavity as well. Okay, so any of those would be considered cord body temperatures. Okay, because of that problem of conduction and convection, we want to make sure that if the patient is wet in any form or fashion, whether they fell in water, whether they got rained on, whether they got hosed down because they were drunk at the bar and creating a brawl, whatever the reason is, we got to remove those wet clothes and dry them off quickly to minimize the continued loss of heat. And then we're going to do what we call active rewarming. So active rewarming involves multiple different approaches, and I'm going to list a bunch of them for you. Recognize that any of these are an option, but we're going to progress from the least invasive to the most invasive, and then we'll go back to one that is least invasive once that person's awake and alert. So let me see if I didn't put it on the slide. I thought I put it on the slide for you. Give me just a second here. Nope, I guess not. Okay, so the first one is warm blankets and a hat. Okay, so remember, as I mentioned a while ago, we lose a lot of body heat, even as adults, from our head, especially for people who have little hair. So you can lose up to 20% of the heat loss from a person's body out their scalp. The next more aggressive approach is what we call a warming blanket or a warming device. If you work at a hospital or maybe during clinicals, you might have heard it referred to as a bear hugger. It's a disposable blanket that we circulate hot air through. We preset the temperature of the air so it stays a constant temperature as it circulates through there. Recognize in order to use it effectively, it must be against the patient's skin. You don't put that on top of their blankets and sheet. You don't put that on top of their gown. You put it against their skin so that, again, through conduction, that hot air begins to warm their body. And then you cover them up with blankets on top of that if necessary, just something to hold it snug against their body. The next one would be warm IV fluids. So again, in the same place we get our warm blankets, we keep IV fluids for times such as this, especially if you're in an environment like Colorado or someplace that routinely has hypothermic patients. The next one is ventilated warm, moist air. So what I mean by that is we intubate these people. And so the ventilator has the ability that we can adjust the temperature of the air that is pumped into their chest to be slightly warmer than their body to help warm them back up from the inside of their lungs. Warm peritoneal fluids. So we can take and put a peritoneal catheter poked into their abdomen and put irrigation fluids, again from that warmer, to help warm their internal organs quickly before they begin to die. Notice how these are getting progressively more invasive. And then the next one, being the most invasive of all, is we warm their blood through external or extracorporeal device. It's very much like a dialysis machine. We literally pump their blood out through a heated unit and then pump it back into their body to warm their blood up as quickly as we can comfortably do so. It's called extracorporeal, meaning outside the corpse. Okay? Not outside the corporal like in the U.S. Navy or whatever. We give it to everybody but him. He doesn't get it. And then the last one is if once the person becomes awake and alert, we can use those warm oral fluids as an option as well. So recognize those first 6 that I gave you are from least invasive to most invasive. The initial ones do not require a primary care provider's order. The more invasive ones do. Remember, from boot camp, anything we put inside a human body, be it device or be it substance, we must have an order for. Okay? All right, next one on our list there is analgesics, because one step further than hypothermia is what we call frostbite. And frostbite very simply means the tissues have actually frozen to the point that what happens to water, are we at Enid yet? I don't remember if I asked you a question, Enid, so this is your question. What happens to water when it freezes? It gets hard and solid, but what does it do as far as space in your ice tray? It expands. So what do you think it does when it freezes in the human body? It expands. So it ruptures cells as it freezes. And as a result, those cells are damaged. And we're going to talk about inflammation here in a moment. But as you rewarm those tissues and you begin to get blood flow back to all those damaged cells, it's painful. So they're going to require analgesics to deal with that as we rewarm those tissues. And then teaching. We want to make sure that the client, once they're alert and awake and is ready to receive learning, an opportunity to teach them how to avoid this situation so it doesn't happen again. Because the next time, they may not have our help to deal with it. And there won't be a survivor in the story. And then referral. Again, some people, the elderly particularly, those on limited or fixed incomes, may have trouble during parts of our country, during those deep winters, being able to stay warm enough in their homes or in their apartments. And so we may need to refer them to financial assistance in order to get help to pay for those utility bills so they can avoid this experience. All right? Oh, there's the slide. Thought I put it in there, I just put it out of sequence there, I apologize. All right. So the last step of our nursing process is evaluation, and we always add documentation as part of that. So when we're documenting, we're going to document our original assessment data, we're going to document the interventions we did, and the improvements that we observed as far as patient responses. What changed in that original assessment data that tells us we made a positive difference for that patient. And then lastly, we're going to document whether or not we reached our goal. What would be our goal, Stillwater, for somebody with hypothermia? Back up to a normal body temperature, and preferably without any of these other substances being infused inside of them. Okay? All right. Any questions about hypothermia? All right. So, before I get started on this, let me just give you a quick commercial. Because we lost so much time with our IT losses again, then there is no formal break for you. Okay, so anytime anybody just has to gotta go, you can go whenever you gotta go, okay? And nobody will think less of you. But Mr. Baird will continue, and so if you miss part of it, you simply just watch the lecture capture, which hopefully that part is working today. It's flashing, so we hope that it is working. All right, so let's continue with each of these 4 types of being too hot. So the first one is heat exhaustion. By definition, it's simply caused by our body's inability to maintain its body temperature because it's depleted all of its fluid electrolytes that it had available for sweating. And so now it can no longer adapt to the environmental temperature it's being exposed to. Okay, so it cannot cool the body adequately. So who's at risk? Well, the very young, if they take on very vigorous physical activity without acclimation. Well, what's acclimation mean?
Getting to the point where you're able to stand that climate?
Yes, very good. So getting used to a standard or routine temperature in your environment. So a lot of times, if you ever discover that from early morning till mid-afternoon, here in Oklahoma, it may change 20 to 30 degrees. That's whether it's in the wintertime or even in the summertime. Well, as a result, if you were to go out in the middle of the afternoon and begin doing something vigorous outside, you're going straight out into 101 degrees or 102 degrees, and you're going to be miserable for the first hour or two for sure. If you started at 7 o'clock in the morning and worked all the way up to that point in time, your body would have adjusted slowly, and it would be almost imperceived, almost not even observable to you. The old, they typically have this problem when they fail to maintain adequate hydration. And we talked about how that's one of the risks for fluid electrolytes for an elderly person, is they don't respond to their thirst mechanism as readily as we do as younger individuals. So what do we see with these people? Well, we see fatigue. We see weakness. They just don't have the energy to do what they've been doing up to that point in time. They may even have faintness or dizziness or actual syncopal episode. They may have nausea and vomiting. They may or may not have an elevation in temperature. It may be on that high end of normal, or it might be in that observing range, so 101 or less. They will feel restless because of that fight or flight response. Their body knows that it's under a threat. They may have a headache, an unrelenting headache. They may be pale and clammy. Now recognize this. Remember, normally we have vasodilatation that occurs. And so normally somebody would be flushed during a time when they would be hot. But when they begin to experience this component of the process, they may or may no longer be flushed. They may actually be pale now. They may have heat cramps. So either their muscles of their legs or their arms or even their abdomen may have a cramping sensation. And that's electrolyte depletion issue. The respirations will be fast and shallow. In other words, we would think of them like a dog that's panting. Okay, they're trying to blow off body heat as they exhale. Their pulse will be fast and often weak because they are hypovolemic. Typically, we will see the risk factor of them working someplace in an excessive temperature, and many times that temperature includes a high humidity. Okay. And many times in our state, that it's when the job is outside. Okay. So what do we do for these people? Well, we want to slow down any muscle activity that's going to generate heat. So we're going to place them on bed rest in a cool environment. And by a cool environment, we're talking about an air-conditioned environment if possible, which typically hospitals are. We're going to remove any excessive or constrictive clothing that might impair blood flow or the dissipation of heat from their body. And then we're going to do the opposite of active rewarming. We're going to actively cool them. So one of the things we can do is we can sponge them off with tepid cloths. Enid, what does tepid mean? It's another word for tepid.
Cool.
I heard something about cool or warm. I think that's what I heard. Well, let me add a little bit to the warm word.
He said
Lukewarm. So anything that's just a few degrees less than that person's body temperature will help them dissipate body heat. If we provide them something that is cold, then what would they most likely do in response? Or they might shiver, and then they would begin to produce more heat again. So we're just going to go just a little below their body temperature and bring it gradually back down to where we want it to be. So that water needs to be lukewarm or tepid. We need to, if they're still awake and alert, provide oral fluid replacement, and sometimes we need to replace some electrolytes. Maybe some sodium, some chloride, some potassium that they lost from their sweating process. So electrolyte drinks like Gatorade are a good option here. Pedialyte is a great option as well, both for adults and children as well. If they're not able to take oral fluids, or if they are severely volume depleted, then we might need to give them IV fluids that have that same electrolytes available to them. And once again, when they are able to take opportunity to teach, we want to teach them how to avoid the situation, because each time they experience it, it will become easier for them to experience it again. And then this too, this group may need some referral, but this time to provide sources of fans or utility assistance to provide cooling measures for those individuals. So some communities here in Stillwater, I've forgotten now what it's called, Safe Harbor or something like that. Anyways, there's a symbol that some public facilities will place on their outside door that indicates that anybody who wishes to can come in out of the heat and basically soak up the air conditioning during the hot times of the summer. As part of what our community is chosen to do here in Stillwater, to help those who cannot afford to cool their own homes. So like the library is a good example of that, the YMCA. I'm not sure of the other places, several businesses, so several stores have them on their windows as well. And I've forgotten the name, but it's Safe Something if I remember right. And then we're gonna evaluate and document the very same things we did before. So what was our assessment data initially, and then what did we do for them? What kind of responses did we get? And ultimately, did we reach our goal? Did we bring that person's temperature back down to a safe range for them? Did we replace their fluid and electrolytes so that it can stay at a safe range again? Any questions about heat exhaustion? All right, let's go to heat stroke then. Heat stroke takes the same situation and goes a step further down the continuum. Heat stroke is where that body temperature now is excessive because of that prolonged depletion of fluid electrolytes. These people now have suffered neurological involvement. They now have the appearance of somebody who's had a CVA. They have neurological changes, not just the other signs and symptoms we're going to look at here in just a second. This is a life-threatening condition and sometimes requires life support measures in order for these people to survive. So what do we see when these people come in? Their temperature will be way outside of. We refer to that as hyperpyrexia, not just an elevated temperature. They have so depleted their fluid electrolytes, they don't even sweat anymore, even though their body temperature is excessive. Their skin will be hot, dry, and they often will have facial or chest flushing. Their body is trying to vasodilate and get rid of any heat that it can. It's just not being successful. They have that marked headache, again, just like the heat exhaustion person. These people have an altered mental status, meaning they may not be able to talk at all. Their speech may be garbled or disoriented. They may be, their personalities may be different, or they may simply have a decreased level of consciousness to a point where they can't even interact with you. The other neuro changes they might have, just like a regular stroke, they may have weakness or paralysis on one or the other side of their body. They may even have seizures. The brain is very vulnerable to excessive heat, and the neurological damage that is done during a heat stroke is oftentimes irreparable. In other words, it cannot be restored. So the changes could become normal, or could become their new normal, if you will. Their pulse will be fast, weak, thready. The respirations will be that panting type of respiration again. And many times we see that they were exposed to a hot, humid environment, many times without opportunity to replenish fluid electrolytes adequately, or maybe not be able to control their exposure. So what do we do for these people? Basically, we do the same thing as we do for the heat exhaustion people, but our cooling measures are much more aggressive. This time we're going to wrap them in a damp sheet and blow fans over the surface of them to dissipate some of that body heat. Or we might use a cooling blanket or device. So much like the bear hugger, it's going to go against their skin, but we're going to circulate cold air now instead of warm air to try to pull that heat out of their surface of their body. And guess what our next slide does? We evaluate and document. Okay? Always evaluate, always document. It's just there. All right, so even though we're not taking an official break, I need everybody to stand up, do about 5 jumping jacks, and then sit back down. Body language is screaming at me, oh, Mr. Baird. No, that's not jumping up. That's only doing your upper torso. So unless you're paralyzed, you gotta get all the way up.
I left my water in your car.
All the way up, all the way up. Oh,
Yeah, but I want that one too.
I still see people sitting down.
The Tonkawa students would like me to let you know that they had Thanksgiving dinner at lunch for us today, so.
Oh, so this is the turkey snooze time, is that what that is?
I think
that's
that they
okay.
wanted to jumping jacks without
Oh, well, if you end up having a nausea vomiting issue, you get the excuse to leave the room. So go ahead and stand up anyways. Everybody stand up.
Yeah, I remember us talking about that.
Everybody in Stillwater, make sure you stood up and done your thing. Okay.
I'm done standing.
All right. Okay, go ahead and sit back down and finish your red alarm.
I guess I could have got I know. I still made it back. No, it sounded like.
I'm going to shift our focus to something that's a different form of too hot. And this one is dealing with something that is not necessarily environmental related as much as, or fluid electrolyte related, as much as something dealing with infection or an organism that's invaded the body. So a fever, by definition, is any temperature greater than the high end of our normal range, or greater than that patient's normal circadian variation. So some of you may have experienced during clinicals this fall, you might have got somebody's temperature and it was 99.0, and the person said, oh, I have a fever. And you say, no, that's a normal temperature. Oh, no. I'm never more than 97.5. And for that person, it very well may be a fever for them. Okay? So we take into account that person's typical temperature range. So what happens in a fever situation is our hypothalamus alters its set point. Remember we said our hypothalamus wants to maintain a normal body range, a normal body temperature within a very narrow range. Well, with the hypothalamus in a fever situation, it changes its mind. And its mind is changed by 2 primary processes. The inflammatory process that we're going to look at first, and then the infectious process that we will look at just briefly today. We won't cover that in great depth today. So once the hypothalamus changes its mind, it expends its time, effort, and energy to raise that body temperature up to that new set point and to keep it there until it no longer needs it. Okay, so if it sets that hypothalamus, sets that new temperature range to 101 to 103, then over the course of this process, it will do its efforts to maintain it between 101 and 103. So let's talk about that inflammatory process before we go further into what a fever is. Inflammation is simply an aggressive local tissue response to injury. And it happens in all tissues of the body, including skeletal tissue, and it happens regardless of the nature of the injury. So the injury might be caused by something physical, so like a blow, or a penetrating type of injury, or a crush type of injury. Or it might be due to something chemical in nature, so it might be exposure to medications or toxins in the environment. Or it might be exposed to things that are inhaled that cause tissue injury inside the lungs. Or it might be a pathogenic cause, pathogenic being viruses, bacteria, fungi, okay? Other examples of physical injury I forgot to mention is burns, as well as the frostbite we talked about, as well as surgery. So that injury could be intentional in nature. So every time the surgeon cuts into that person's abdomen or some other tissue, they are creating an inflammatory process. for that person. Inflammation's primary purpose is always the same, to limit the injury to that area and to restore that tissue, if possible, to its original state. In other words, to heal the tissue. It's to confine it and to heal the tissue. And regardless of what caused the injury, physical, chemical, pathogenic, doesn't make any difference, the steps are always the same, but they're not always pathogenic in nature. So what does it look like for us as a nurse? Well, there are 5 primary signs and symptoms. And you need to know these like the back of your hand, because many, many, many things that we deal with as nurses have an inflammatory component to them. First one is heat. And in just a moment, I'm going to go through the steps and I'll explain where that heat is coming from. But basically, the area feels hot in comparison to the tissues around it. There is redness. In other words, there's an abundance of blood in that tissue that is causing it to look more red than it normally would. There is pain. Inflammation always produces pain regardless of where it occurs. There is swelling. And again, I'll explain that as we walk through the process in a moment. And then lastly, this is the one that gets overlooked the most. There's a loss of function. Inflamed tissue doesn't work well. Kind of like when you don't feel well, you don't produce your best effort or your best work. Well, that's what happens with our body tissues as well. Not all inflammation produces a systemic response, but when it does, that systemic response will often then include a fever. In order to produce that systemic response, there's a complex series of events. And those series of events involve different elements in the bloodstream, so different components of the blood itself. It involves antibodies, and it involves white blood cells. But the reason for that series of events is what I said earlier. It's intended to limit the spread of the problem and to restore tissue. When there is a systemic response, it typically involves what we call pyrogens. Those pyrogens are substances released into the bloodstream that cause the hypothalamus to change its set point. Pyro meaning fire, gen as in generates. So when those pyrogens get to the hypothalamus, they generate a heat-producing response. Those pyrogens can be released by the white blood cells when they recognize, ooh, we're dealing with a pathogen here, not just a blow to the tissue here. Or it can be the bacteria itself releasing toxins. So there are things that bacteria release into our surrounding tissues that get picked up into our bloodstream, and then they produce a fever response as well. So the end result is that hypothalamus changes its set point. It begins to produce more heat than it normally does and decreases heat loss in order to maintain that new body temperature that it now perceives is its new normal. Okay. All right. So let's talk very briefly about the process. This is to promote your understanding of those 5 signs or symptoms. It's not simply a list of things for you to memorize. That's not going to serve your purpose as a nurse. But if you understand the process, then the signs and symptoms are easier to learn in a way. Basically, an injury occurs. And because our body wants to limit the spread of that injury, it does not know initially whether or not that injury was pathogenic in nature or not. So immediately it's going to constrict the blood vessels to that local area to try to keep anything from hitching a ride and being dispersed throughout the body. And then there's going to be some chemical mediators released. And those chemical mediators, for those of you who just want to know, are things like histamine and bradykinin. And they are going to tell the surrounding tissues how to respond. So the next step, ironically, we vasoconstricted first, but now we're going to dilate. But the reason we dilate is so that we can increase the ability of the things in the blood to leak out into the tissues. In other words, what we want is for the white blood cells and the antibodies and the fluid and nutrients they need to do their job to leak out into that interstitial space in order to fight the invading organism and to build tissue. But we still want it to all be contained right there. So our body's going to create a wall around the area called a fibrin barrier. And then it's going to go to work and hopefully be able to keep everything contained there until everything is better. Okay? So when we see this process, the increased heat is coming from that vasodilatation. We're getting a lot of blood flowing to the area, and it's going to produce that increased heat. When we see the swelling, it's because of that capillary permeability. That's when those white blood cells and serum are leaking out into the tissues to promote healing. When we feel the pain, that's in response to the histamine and the bradykinin being released. They trigger our nerves to feel pain. Okay? All right. And then the loss of function is just, if you remember, we talked about how anytime there's increased fluid in the interstitial space, it takes longer for things in the bloodstream to get to the cells because they have to travel further than normal, and it impairs the body's ability to do whatever it does. So if it's your liver that's inflamed, we can always tell what the physician is looking at as far as inflammation because the word ends with itis, itis. Okay, so hepatitis is liver inflammation. Okay. Appendicitis is appendix inflammation. Cystitis is, cyst refers to the urinary bladder, so it's a bladder inflammation, etc. So what do we see as far as the healthcare team and their lab work is concerned? Well, there are two primary lab tests that we're going to look at, and those lab tests will indicate that inflammation and possibly infection are occurring. So the first one is our white blood cell count, and we may see an increase or what we call leukocytosis. Okay, so that leukocytosis means it's greater than our normal range. So our normal range for an adult, a healthy adult, is 5 to 10,000. And so anything above 10,000 indicates either inflammation or possibly infection is occurring. Oops, sorry, clicked one time too many. So let me go back here. ESR stands for erythrocyte sedimentation rate. And basically, remember I just told you, during times of inflammation, we form this little wall around the tissue damaged area. And it's primarily produced with red blood cells and platelets. And so it's like a clot, if you will, to wall off anybody so they don't get escaped. Maybe you've seen movies where sometimes they pull up the castle bridge so that the enemy who's invading the castle can't escape. And then all the knights who belong in the castle have free reign to take out the enemy because the enemy can't get away. Well, that's kind of what this is all about as well. So part of the process of that fibrin barrier being formed is our red blood cells want to play ring around the rosy. They want to take a hold of each other's hands so that none of the bad guys can get past them. And so that's what we call platelet aggregation. So the platelets and the red blood cells begin to clump together. So at ESR, when that occurs, that means that there's been injury somewhere in that body that's triggering our blood to want to make clots right now to protect itself. So an elevation in our SAR indicates that inflammation is occurring somewhere. Doesn't tell us where, just means it's happening. So stages of a fever. All right, I would like to show this on the document camera, but I'm going to postpone that because once I mess with the document camera, we may lose our connection altogether again. So I'm going to hold the explanation of this part till later, and then if we switch to the document camera and can't get back, we'll be okay. All right? So hold on to this idea. These 4 words are different than the ones that are in your textbook. To me, they make better sense. They're from a previous edition. They're easier to comprehend than deferescence and whatever. It's like, what does that mean? Okay, so I used the simpler term for you to help you learn, and we'll come back to that. I've listed 4 fever terms that you might hear in conversation. It does not mean that you necessarily have to be the one wielding them, but basically an intermittent fever is that the fever is coming and going between normal temperature or even a subnormal temperature in a fever, and it happens at fairly regular intervals. So an intermittent fever often coincides with somebody who has a viral infection. So somebody who has a viral infection will many times feel just fine for the early morning hours until about mid-afternoon, and then the fever kicks in again and goes up until about their bedtime. Why does a virus do that? I don't know the answer to that, but that's an example of an intermittent fever. A constant fever is there's a narrow range of change in that body temperature, but everything you checked is above normal. It never drops back to normal. A fever spike is when a temperature grows into a fever range very quickly and then may subside just as quickly. And then a fastigium is the highest point of a fever. Again, physicians use that to indicate whether it's most likely a viral viral infection versus a bacterial infection. For an adult, bacterial infections typically produce constant fevers and very high fevers, as opposed to a virus. So when are the common times that we might see a fever occurring? Well, anytime a patient is compromised, then it can lead to them being vulnerable to invading organisms. So that would be a compromised person might be somebody who, because of age, so the very young, the very old. Nutrition, so anybody who is malnourished or is not meeting their protein and vitamin need, especially, is a compromised patient who's vulnerable to infection. So once again, the impoverished, the elderly, those who are dependent upon other people to feed them, could fall under that category. People who are under stress. Stress affects our immune system and makes us vulnerable to infection. Environmental exposure, so people who travel to areas where they might encounter new organisms they've not been exposed to before are vulnerable to infection. Somebody with chronic illnesses like diabetes that affects our blood sugar makes us vulnerable to invading organisms. Acute illnesses like cancer makes us vulnerable to invading problems. And then when we start treating those individuals, or we treat those individuals who have autoimmune diseases, then those who are immunosuppressed are vulnerable to have a fever and an infection. And then lastly, those who have alcohol or drug abuse on a routine substance problem, then they typically expose themselves to a lot of risky situations, and as a result, they too are commonly compromised in their nutritional state, in their immune state, and in their risk involvement. The next time is when we have a known exposure to a pathogen. We refer to that as an epidemic. So through study, through the media, through our Center for Disease